Now, proud and honored to present Dr. Craig Wax, a private practice physician. He's engaged in the fight to restore the patient and physician relationship and to give patients their healthcare power back. Dr. Wax hosts Your Health Matters on Rowan Radio, 89.7 WGLS-FM. Dr. Wax serves on the editorial board of Medical Economics Journal. Dr. Wax?
Thanks to Dr. Hughes and Mr. Schlafly and all that have gone before today, Dr. Kempen as well, to kind of set the stage for this. The 9 most terrifying words in the English language are, "I'm from the government and I'm here to help." We all remember former President Ronald Reagan said that, and we have the halls of medicine here, and we brought in the Trojan Horse, basically, and we were told lots of great promises of why the horse was here and how wonderful it is, but let's find out what's inside the Trojan Horse. So why adopt EHR? Well, we were kind of sold a bill of goods here. The payoff is safer, higher quality care, cost savings, privacy protection, and healthier people. All sound like great goals. I think everybody in this room could get behind that, and every patient in our country could get behind that. The problem is none of them are tested or true, and there's no data to substantiate any of them. That's indeed the problem. So it's a huge Petri dish experiment that has failed in other countries. Dr. Hughes had also mentioned previously in the UK, a bit of a smaller country with a few less people, they gave up in 2012 trying to integrate their systems. It was too expensive and too time-consuming. And they had decades to try, and we're all kind of newbies at this with our American ingenuity. So you can see the big bubbles here in the American Reinvestment and Recovery business model. HHS, big bubble. CMS, largest payer. Veterans Health, big. Where are we? Well, I'll give you a hint. It's right below the carrot and stick. And anybody who has done any work for the federal government, whether Medicare, Medicaid, or any other, it's the carrot and stick method. It's here's the carrot, chase the carrot, chase the carrot, chase the carrot. Okay, you didn't do what we said. Here's the stick, here's the stick, here's the stick. You won't get paid. We'll take money back. Reclamation. Lots of problems indeed. So this is our little bubble here. And I still have yet to see a patient population pop up on any of these graphs. So why adopt EHR? Why wouldn't we do it? In fact, if it was good and the technology existed and it improved care, it saved money, it created efficiencies, physicians would already be doing it. So what did the government say? Well, it's time to get connected because we need control of the entire healthcare section of the economy. That's what the Office of National Coordinator for Health Information Technology said around 2010. Begin participating in 2011 and 2012 and earn up to $44,000 for Medicare and $63,000 for Medicaid. Well, that sounds like a wonderful promise, but what kind of a promise is it, and what's it going to take to jump through those hoops? Certified EHR technology can help improve the quality of health outcomes, the efficiency of healthcare, while providing privacy and security safeguards. We were all sold that bill of goods. These are 3 fundamental lies, not based on data. So, of course, we're all familiar with HIPAA, and HIPAA is a great idea in concept that we should all value the patient-physician relationship and keep everything private, not share it inappropriately, and only share it under appropriate circumstances. But whenever the Fed gets involved, I'm sure you guys remember the early days of HIPAA 6 or 7 years ago when you could call a hospital about your patient and the nurses couldn't even talk to you on the phone. You couldn't speak with other physicians. You couldn't even communicate and do the work that you were supposed to do because HIPAA then created potentially a federal problem for the person sharing the information. So you'll notice covered entities, well, we're number one, healthcare providers. I'm not big with providers. Just so you know, the word provider came up around 1970. That's the master of the plantation. That's the insurance industry speech for anybody that they may have to pay at some point. So and it was originally applied to physical therapists. So anybody that they had to potentially cut a check to became a provider. And potentially, I guess, a source of backward revenue if they we're able to hold that reimbursement back for care already given in good faith, and it happens every day. So, and our business associates also. Do you do electronic billing? Guess who's covered by HIPAA? You are. Anytime you do electronic billing, you are covered, and you're on the hook for that. The health plans are covered, and healthcare clearinghouses. And I'm still trying to figure out what a clearinghouse is. Apparently there's somebody you have to pay to do something with data between you and the insurance company. And I haven't yet figured out what one is. HIPAA security rule, again, they promised everybody, they promised physicians, they promised patients, they promised taxpayers that they were going to be secure and private. Well, the government doesn't really have the power to do any of that. What do they have the power to do? Well, you remember the carrot and you remember the stick. Well, they have a big stick, and we're going to talk about how big their stick is in just a minute. No pun intended, ladies and gentlemen. So anyway, you have to do risk analysis and management, administration safeguards, you have to have access management, workforce training and management, constant evaluation, you have to do physical safeguards, technological safeguards, and the big question that all the consultants want to sell you, are you prepared to respond to a security breach? Well, let's find out why. Civil money penalties and criminal penalties. Well, ladies and gentlemen, Houston, we have a problem. HIPAA violations can cost between $100,000 to $50,000 or more per violation. That's per violation when they come to your office and say, doctor, we need to have access to your EHR, please, so we can have all of your data and judge you by it. The good news is, well, it's sort of good news. There's a calendar year cap of $1.5 million. So the worst you're going to be on the hook for is about $1.50. That's about it. So I don't know about you, but I don't have anything in my life worth this. My house, my practice, I don't know. I don't have anything that's worth that. So we're going to have a lot of difficulty with any potential problems, perceived or otherwise. And there are also criminal penalties. How would you like to be listed on the website of shame? Anybody for the HIPAA website of shame? Who's had the latest information problem? So if you want to Google Redspin's breach report, they come out every year since 2009. And since 2009, since they've been keeping records, 804 large breaches have occurred, affecting over 29 million patient records. I mean, that's a mind-boggling number. 29 million records have been breached. They've been potentially bought or sold or lost or traded or pirated or stolen. It's a huge, huge number. So in your handout, I included some of this data. Let's just hit some of the high points. 137% increase in the number of patient records breached in 2012 and 2013 over the previous 2-year period. So it's gone up considerably. 4 million records were breached in the largest single incident. And they want us to electronically prescribe. Not only that, they're penalizing us if we don't electronically prescribe, and their plan for us next is to electronically prescribe narcotics. Anybody want electronic prescriptions for narcotics? I mean, you know, maybe someone might steal one of your pads or something, so you have a bad day, you've got to alert the police, you got to look for that. Can you imagine if somebody, God forbid, gets your password? How many millions of narcotics you would prescribe and be on the hook for? Think about that for a moment. Okay, apparently the writing gets smaller as we go along. Sorry about that. The EHR reality. We had just talked about that $40,000 starter seed money that the government wants to give you. Well, that's if you can get through 3 levels of meaningful use. Now, they invented meaningful use because when I considered EHR, I thought, hey, maybe this might be a good idea. Maybe it's possible, you know, with the academic in me to try and improve patient care, make things more efficient, more convenient for patients. However, meaningful use was an invention of the government. It's not your meaningful use or the patient's meaningful use. It's their data collection meaningful use. So stage 1 was pretty straightforward. Stage 2 was bizarre and Byzantine and gave patients access to all of their medical records online, where, in my opinion, whether you believe that should be or not to be, because there's arguments either way, whether a patient should have all access to everything. If the patient has access to everything online, anybody has access to things online. I mean, it doesn't take a genius to figure this out. So having said that, the best case scenario when you install EHR per Modern Health in March of 11 was $46,000 per physician for the first year. So imagine you were able to jump through these incredibly high hoops for stage 1, stage 2, and stage 3, and you got all $40,000. Well, maybe you paid the first year off, possibly. However, there's lots of things that they don't figure in there, like time and effort, and when you're in an exam room doing a procedure or an exam and the staff is contacting you because, hey, my computer has logged me out, or the internet has kicked me off, or whatever it is, you become the IT help desk at that point. So after you get through that, assuming you do break even, well, what about years 3, 4, 5, 6, 7, 8, 9 to eternity? Well, guess what? Now that's your liability, that $46,000 every year. Add that on to the $68,000 that you pay in staff and an ability to electronically bill the insurance companies. I mean, even the AMA's data from 4 years ago say we all spend at least $68,000 on that. And that's huge. That could be spent on patient direct care. And it could be done at a fraction of the cost when our offices have to swell up to accommodate all of these mandates. So there are privacy risk, data breaches. We spoke about malfunctions costing time and money. I'm sorry, the internet connection's down. I can't be a doctor right now, so all of you in the waiting room will just have to, I don't know, sit. I'll call my internet provider, I'll check on this, or my software consultants. You know, they're always available for $150 an hour. You can always get a consultant pretty much any hour. So having said all of that, as I mentioned, there's no ongoing revenue stream after 2014. So all of this is on all of you and everybody else in the healthcare system that provides any kind of service. And the worst part about it is with all of this effort and time and money, I guess they call it in construction T&M, study looks for can't find much evidence of e-health's benefits, Wall Street Journal in 2011. So there's no benefit, there's only costs, and they're to be borne by everybody who provides a service in good faith. I got a problem with that. I hope everyone here has a problem with that. Also, there's risk of insurance money recoupment. They can go back into your EHR. Do you think denying you based on codes was bad? They can go into your EHR and say, you know what, doctor, from 3 years ago, we're not going to pay you for that. And you're like, but you already paid me. Well, we're going to just take it back from future checks, so you don't have to worry about that. And we could have any member of the room probably talk about RAC audits, that is to say the Medicare audits, where the government is paying private headhunters to come to our offices and go through all of the records and billing to try and find places where they can steal money back. And I actually had someone of interest with that call my office and say, hey, Dr. Wax, we paid you 4 years ago $150 and we don't think we should have. So I went back and I pulled all the records and I said, yeah, this was absolutely perfect. You need to do that. And they said, well, you can't appeal. It's too late for you to appeal. Just give us the money. So there wasn't even a fighting chance. So also, they can also take back their EHR incentives. So remember I talked about that $40,000 potentially pie-in-the-sky carrot that they're offering for stages 1, 2, and 3? They can be able to come back and take, I'm sorry, you dropped out of the program, I'm just going to take the money back. Major glitch for digitized healthcare records, and I came up with glitch before the current administration decided that everything about healthcare.gov was to be called a glitch. It wasn't a tragedy, it wasn't a travesty, it was a glitch. I'm sure you saw that on CNN and all the other networks. Wall Street Journal, 2012, savings promised by the government and vendors of information technology are little more than hype. Again, very expensive, not worthwhile. Nobody tested it. Not physician-friendly, not patient-friendly, not anybody-friendly, but government and IT industry-friendly. In fact, the IT industry lobbied your Congress people for this. This was partially their idea. Legal risks of going paperless. This was actually in the AMA News in 2012. System breaches, modification allegations, new e-discovery demands, EHRs and new tort claims. It's primarily untested what happens with an electronic health record when you get sued. Perhaps my colleague, Peter Leone, who has 2 decades of experience with Princeton Insurance and is always defended doctors in his career, and I certainly, and all of us in this room appreciate that. Thank you for your efforts, ongoing. If anybody wants more information on EHR, I did a presentation 2 years ago for the Association of American Physicians and Surgeons called EHR Privacy and Security, Mission Impossible. It can't happen. It is impossible. There is a patient-level presentation that we did for a town hall in northern New Jersey here for 15 minutes, and then there's a physician version you might gain some benefit from for 35 minutes. So here's the other Trojan horse that Dr. Jane spoke about earlier, the Obamacare Trojan horse for the Unaffordable Care Act. That is to say, health care reform and all the IRS agents swarming out of it in the dark of night. Welcome to the era of big data. All the academics on high and the government are saying, hey, big data is going to save us. Well, I got news. Big data comes from the top down. It doesn't come from the bottom up. The patient-physician relationship is what made medical care exceptional in this country. And if we allow them, that is to say the government, even our own governing bodies through MOC and OC and MAL, sorry again, acronyms, we'll discuss acronyms in the second presentation. Data equals power. Patients and their physicians should own it. So whether you're talking about ACOs, bundled payments, cost-effective systems, health information technology, reform initiatives, the keystone right at the top is EHR. So EHR, the Trojan horse, the summary. EHR are government, insurance, and corporate Trojan horses to get inside the exam room, digitize the patient and physician interaction, control patient resources from afar, and marginalize the physician and the patient right out of the relationship, both parties. EHRs replace human continuity with electronic continuity. I'm sure all of you that have practiced in this room say, geez, I know Mrs. Smith. I take care of her husband, I took care of her mom, I take care of her kids, or whatever your certain practice circumstances are. They want to replace that human touch with electronics so that they can do a similar ones and zeros interaction at any CVS, Walgreens, Walmart, or any other place, and they can substitute whoever they want. I mean, today it's nurse practitioners, physicians, assistant that are, trained in their training. It could be anybody, it could be any sort of assistant. I mean, I can't imagine the government allowing paralegals to practice and argue cases. Mr. Schlafly, maybe you could address that at our next meeting. So it's important that we defend the patient-physician relationship. In fact, this was driven home for me when I had the privilege of speaking with and interviewing Dr. Jane Orient, who's the Associate Director of the Association of American Physicians and Surgeons, which has been paramount since 1943 in trying to keep government, insurance, and all other parties out of medicine. She told me it's the patient-physician relationship because it's the patient who comes first. That is huge. That is paramount. Also, EHR will be used for maintenance of certification, osteopathic continuous certification, and eventual maintenance of licensure. It is the strings that bind. It draws everybody in. It's like shoelaces. It's going to keep the whole practice of medicine under wraps. So what can we do about it? Well, what have we done about it? Well, lawsuits like the AAPS against the ABMS are one helpful step through the courts. But everybody can be active in this room. In fact, there are doctors in this room who were involved at help foiling the government spy plan that I wrote about in 2011. Does anybody remember when CMS and Medicare was going to send fake patients to your office? They were going to call up to ask questions, and they were going to come in with fake illnesses and things, see how you treat them, to see if there was malpractice. To me, that's entrapment. That's government entrapment. They're not even finding a problem, they're creating a problem. So what we can do is, we talked it up, everybody got on news shows, people spoke with patients, and the whole country decided this was unethical, this had to stop. And the administration said, okay, put that away. Maybe pull that out later when nobody's looking. So very important, we stopped that government spy plan. So what else can we do in our own private offices? To go direct care, bill patients directly. We can post our prices. We can deal directly with patients. We can deal with employers. We can deal with companies, anybody that is directly responsible. But the patient has to be the most important feature, and the patient has to be directly involved. Because if you don't do electronic billing, no insurance, no government, Medicare, or Medicaid, guess what? No HIPAA. No HIPAA. They can't come to your office. In fact, it's been tried. It's been tried. They've tried to find people with HIPAA violations, but if they only bill patients directly and ethically, HIPAA doesn't apply. So choose paper charts or electronic health records at your own peril, whether server or cloud-based. You have to do it based on your own risk tolerance. Whatever makes it best for your patients and you and your staff. That's the most important thing when it comes to a record choice. And also, I'm sure the legal profession can tell us that we have a lot of experience with paper charts, you know, how to defend them and what to do with them. We have very little experience with electronic health records. Very little experience, and the e-discovery is going to be unbelievably complicated with regard to that. So I recommend keeping it simple and straightforward. Fight osteopathic continuous certification, maintenance of certification from ABMS, and maintenance of licensure. It's just ways to control what you're doing. The government wants to control costs desperately. That is their only interest in this situation. And the way to do that is through control. Control of everything that we do every day and whatever your patients do. But patients have to have the free will and freedom to follow their bliss. So do we. That's what differentiates us as physicians, each of us, even from each other. Do not share data. If you share your data, even if the government says, hey, we'll give you a percentage point, share your data. Well, guess what? Well, guess what's going to happen? That was the carrot. Next year, here comes the stick. We're going to start penalizing you if you don't give us the data. And then we're going to maintain your certification by that data. And we're going to charge you for the privilege of maintaining your certification and your license by that data. So don't interface with government, insurance, hospital health systems. I'm sure everybody feels their hospital in their town is a great supporter of their practice. I know two of the ones that I'm associated with opened up a primary care and urgent care center right in my town, but I'm told it's to help me. So it's good that that'll be supportive of my practice. In fact, I asked them, I said, well, if you really want to help me, be there from 9 p.m. to 9 a.m., because that's when I really need somebody. And they said, well, we're going to be there from the other 9 to 9. And I said, well, so am I. Gee, that's a coincidence, isn't it? I'm thinking not a coincidence. Also, your professional societies, they're going to want the data for maintenance of certification, and that's just plain not acceptable. So thank you very much.